thanks to everyone for coming to the webinar. I'm just going to ask Sonia for a quick thumbs up if you can hear me okay and my slides look all right.
Yep, can hear you perfect and the slides look grand. Thanks, Ruth.
Okay, thank you. So as Sonia said, I'm going to present the experience of evaluating a policy in the UK that provides vouchers for low-income pregnant women and mothers. And as we know, that having a good start in life and during pregnancy and infancy is important for living a healthy and longer life. Sorry. The UK and other governments have strategies and policies in place that can impact on maternal and child health, and it's important to have robust evaluations of such policies. And in this presentation, I'll describe our attempt at an outcome evaluation of the Healthy Start Voucher Scheme. So the Healthy Start Voucher Scheme is a targeted scheme for low-income pregnant women and their children and in the UK. It has changed a little bit from the time that we undertook the analysis, but the scheme in place when we did our evaluation was for pregnant women and mothers of children under 4. And if they're in receipt of means tested benefits, they were eligible to receive vouchers to spend on liquid milk, formula milk, fruit and vegetables, and they receive free vitamins. And really it's designed to provide additional assistance for low-income families to improve the nutrition of pregnant women, to increase their fruit and vegetable intake, and to initiate and maintain breastfeeding, and also to introduce solid foods in addition to milk as this part of a progressively varied diet when the infants are 6 months old. And the vouchers at the time of the study were worth £3.10 per week. The effectiveness and cost effectiveness of the Health Start voucher so far hasn't really been shown. A previous comparison of the Healthy Start voucher scheme, comparing it to the welfare food scheme, found that mothers that were eligible for HSV reported higher daily intake of iron, calcium, folate and vitamin C than mothers that were eligible for the welfare food scheme. And 3 months postpartum, the Healthy Start voucher mothers again reported higher iron, calcium, folate and vitamin C intake, as well as higher consumption of fruit and vegetables. There's been a previous mixed method study of practitioners and low-income mothers, and they found that the recipients valued the vouchers, but there were substantial barriers to accessing, including low levels of awareness of the HSV amongst both mothers and practitioners, and kind of uncertainty about the eligibility criteria among health professionals. And a report on the operational aspects of the Healthy Start vouchers concluded that a comparative study is needed to assess the effectiveness and cost effectiveness of the Healthy Start scheme. And the report addressed kind of issues of eligibility and uptake of Healthy Start vouchers and recommended that we should be determining the effectiveness and cost effectiveness of these population-based feeding programmes. And interventions such as these need to be evaluated in larger studies using a wider range of outcomes with longer term follow-up, and also using methods that are appropriate for deriving causal inferences from observational data. And this is really where this project comes in. So the aim of this project was to evaluate the Healthy Start voucher scheme. So does it improve the nutrition of pregnant women and the health outcomes of their infants? As the policy was already in place, we as researchers were not able to manipulate the exposure to the intervention, and there was no random allocation to receiving Healthy Start vouchers or not. So because we couldn't conduct a randomized control trial, we used a natural experiment design. It was a mixed method study where we combined a quantitative evaluation with an integrated qualitative study. And within that, we did secondary analysis of 2 existing data sets, the Growing Up in Scotland data set, which is representative of the Scottish population, and the Infant Feeding Survey, which is representative of the UK population. We also interviewed mothers to get more of an understanding of the processes involved in the take-up and the non-take-up or discontinuation of Healthy Start vouchers, the experience of using the Healthy Start vouchers, and how the vouchers are actually used. In this study, we had 3 comparison groups, and I'll go into each in a little bit more detail. So this diagram here represents the population of pregnant women and mothers and how they relate to Healthy Start vouchers. So in the sort of darker green group, we've got a group of women who are eligible and claim the Healthy Start vouchers. So they're the recipients of Healthy Start vouchers. And just right next to them in the paler green box, we've got people who are eligible for the Healthy Start vouchers, but they don't claim them. And then there's a group who are nearly eligible. So the pale blue oval shape they're ones who they're nearly eligible for Healthy Start vouchers. So they might have a slightly higher income, so they're not eligible. But in terms of other circumstances, they're quite similar to the eligible women. And then there's this wider group, the rest of the population of women who are quite far from the eligibility criteria. So the comparison groups that we used were the recipients versus eligible. So we compared those who were eligible and claimed the Healthy Start vouchers, the recipients, to those who were eligible for the Healthy Start vouchers but don't claim them. Then our second comparison group were the recipients versus nearly eligible. So the nearly eligible ones are those who just miss out on the eligibility criteria. And then we combined the everyone who was eligible for Healthy Start vouchers regardless of uptake. So the two green boxes were combined into the all eligible group. So the recipients and the eligible, and we compared them to the nearly eligible. So it's like an intention to treat analysis, really. It's how the policy is working in practice. So in summary, we have these three comparison groups, but we still have a concern. The mothers are not randomly allocated to these groups. So how do we ensure that we're making fair comparisons across the groups? So we used propensity score matching, and a propensity score really it's the probability of being assigned to a treatment is conditional on observed baseline characteristics. So the method sort of tries to mimic the characteristics of a randomized control trial when you can't do a randomized control trial, but you do have data on, or other data, sorry, on people. And this technique can minimize the selection bias, and it's kind of better at getting to a causal effect than just simple covariate adjustment in the models. We're examining a range of outcomes, and these are related to child growth, child morbidity, feeding patterns, and maternal health. And each of these outcomes relates to at least one of the four aims of the Healthy Start voucher scheme. So some results for the primary outcome of vitamin use and breastfeeding initiation and duration. You can see that for all the comparison groups, there's no difference in the proportions. So the first two columns compare the recipients with the eligible but not claiming group. The second are the recipients compared to the nearly eligible group, and the final columns are the all eligibles. So that's combining those claiming and not claiming compared to the nearly eligible. And you can see that there's slightly more breastfeeding initiation in the nearly eligible group, but it's not significantly different. And there's not much difference in the length of time of breastfeeding. For child growth and feeding outcomes, again, there's not much difference between the groups. There are slight differences with higher proportions in the premature group, comparing the recipients to the nearly eligible group, and there's slight differences in mean birth weight, but this isn't seen in the proportion of low birth weight. And this slide shows maternal health, and you can see some stronger differences here with mothers in receipt of the Healthy Start vouchers having poorer physical and mental health as measured by the SF12 compared to the nearly eligible group. And they've got higher proportions of smoking too, but there's no differences in the proportion of alcohol use. And these are the results for Growing Up in Scotland study, but we did find similar patterns in the infant feeding study. We did a qualitative interview study with 40 mothers, and that was really to understand their perspectives on the Healthy Start voucher scheme and how it might impact on their and their child's health. And in this study, we had mothers in the all categories. So we had mothers in the category of recipients, eligible but not claiming, and the nearly eligible group. And from here, the main findings were that the main reason for non-uptake of the vouchers was lack of awareness. And this awareness was especially poor among women in employment, women with a higher education compared to claimants, and those living in less deprived areas. And some women, or lots of women, reported learning of the scheme after their baby had been born, so they'd missed out during pregnancy. And in terms of nutrition, providing a healthy diet was important, and the mothers did demonstrate sort of innovative and resourceful ways to ensure their children ate what they believed was a healthy diet. And they did report using the vouchers to buy fresh fruit so that the children could try this fruit and vegetables, and without the vouchers they wouldn't necessarily have bought these fruits. And a sort of key feature of this mixed methods approach is the ability to integrate the findings between the quantitative and the qualitative studies. And the accounts of the women in the qualitative study can really be used to inform the findings from the quantitative study. And there may be a number of reasons that the quantitative analysis was inconclusive. And there was 5 themes that can help explain this. So women were not using the vouchers during pregnancy. Often participants were not made aware of the Healthy Start voucher scheme until their baby was born, meaning they had missed out on quite a few months of not claiming. The opportunity for health professionals to discuss nutrition wasn't used as much as it could be. There was little evidence of discussions with health professionals about nutrition. And then when there was discussion, it seemed to come at the wrong point in the child's life. The vitamin component of the scheme was used less frequently than the vouchers for the milk, fruit and vegetables. And women, there was quite a bit of confusion about the vitamin scheme. So they were confused about the need for vitamins. There was also confusion about how the voucher part works for the vitamins and where in the vouchers can be redeemed for vitamins. I think the vitamin use component has changed quite a bit since we conducted our study. Also, living on a low income posed a kind of range of challenges to mothers. Mothers talked about how they were, how were they meant to pay their bills with limited income, and this aspect of lives of low income women, I think, is quite crucial to understand the constraints operating when you're trying to, provide a healthy diet, and it kind of mitigates any potential impact of the Healthy Start voucher scheme on the child and maternal health outcomes that we had in our study. And one of the other aspects is that the monetary value of the Healthy Start voucher scheme is low. During this study, it was £3.10 per week. And really, that's probably the likely main reason for the inconclusive results of the quantitative analysis. It is unrealistic to expect such a small sum to make a difference to the maternal and child health outcomes that we had available in our data. As with all research projects, there were a few challenges. We had the challenge of evaluating a national policy that was already in place. The Healthy Start voucher is a national policy, but it was targeted to a particular population, and it was quite difficult to find a suitable control group. Obviously, there are plenty of families who are not exposed to the policy, but they are not a good control group because they differ in terms of the eligibility characteristics for Healthy Start vouchers. But we did try to overcome that in our design and analysis. We were able to find 2 existing data sets which identified the exposed group and the of those claiming Healthy Start vouchers. And I think a further challenge of using existing data sets is that the data not only had to identify these exposed and control groups, but they also had to collect measures relating to sort of nutrition outcomes for mothers and children. And we really had to rely on the measures that were collected in these existing data sets. So although we tried to address nutrition outcomes, we were not able to measure sort of dietary intake for mothers and their children. I mean, evaluating the health outcomes does have implications for policy. The Healthy Start had little or no effect in terms of improving vitamin use in breastfeeding and lots of the other secondary outcomes. But I think our results also show that the vouchers are not detrimental for breastfeeding. One concern is because they can be used for infant formula milk, that would de-incentivize breastfeeding. There are also potential risks or harms to the population because use of a voucher can lead to more disposable income that you can then spend on unhealthy items. And we were able to assess the health behaviours of the mother. And we did find there was increased smoking in the recipient and the eligible group. So we need extra policies really to reduce smoking in these groups, as well as the Healthy Start vouchers. But these results could also lead to recommendations for improving uptake in certain groups, which might lead to a reduction in inequalities in the outcomes. And also just taking a sort of slight step back from the actual Healthy Start vouchers and the links to outcomes, the Healthy Start voucher attempts to influence behaviour. So this evaluation can inform other policies that are aiming to change behaviour, and so it can add other information about voucher incentives for behaviour change. I'd like to finish by acknowledging our funders and the research group, in particular Masood Borajerdi and Susan Brown. Thank you.